Hi, my name is Ashley Allen and I'm going to be performing a head-to-toe assessment. Prior to this video, I have received consent from my patient and I have washed my hands. Okay, so I'm going to begin. Hi, can you tell me your name and date of birth?
Robert Hertzbach, August 15th, 1990.
Thank you. Okay, so I'm going to start by inspecting the head. My patient's head is normal cephalic and it is proportional to his body. There are no masses or lesions.
Thank
you. Okay, so I'm also going to, can you remove your glasses for me really quick? Thank you. I'm going to palpate the temporal arteries. Okay. And I can feel the pulsation. It's even on both sides. So now I'm going to test for the temporal mandibular joint to see if there's a click. If you can just slowly open and close your mouth. Thank you. Okay, there's no click. And now I'm going to test cranial nerves 5 and 7 by asking my patient to clench his teeth. Like this. Thank you. Puff your cheeks. Okay. And raise your, scrunch your forehead. You can like over your cheeks, just scrunch your forehead. Okay, and close your eyes as tight as you can. Okay, good. Thank you. Okay, so now I'm going to inspect the eyes. I'm going to note that my patient's palpebral fissures are horizontal and symmetrical. Cranial nerves 3 and 4 by having my patient follow my finger through the 6 cardinal fields. So if you can just keep your head still and follow my finger, okay? Okay, good. Okay, so the cranial nerves 3 and 4 are intact. Okay, so now I'm going to perform the confrontation test to check my patient's peripheral vision. I'm going to sit directly in front of my patient and I'm going to ask him to cover his left eye while I cover my right eye. Okay, and I'm going to have him let me know when he can see my finger in his periphery.
I can see it.
Okay, good. And it was around the same time that I could see it, which is good. It's indicating that my patient's peripheral vision is intact. Okay, so now I'm going to dim the lights and I'm going to use my light to check for Perla. So I'm going to come from the side and check my patient's pupils. Okay. One more time. Okay, so the pupils are equal, round, and reactive to light and accommodation, which is good. Okay, so now I'm going to move on and inspect my patient's ears. I'm going to just note the color, and I see that they're pink and consistent with his skin tone. They're symmetric, and I'm going to palpate them to make sure that there's no tenderness. Do you feel any tenderness?
No.
Okay, good. Alright, so now I'm going to move on to the nose. My patient's nose is symmetric. It is midline with his face, and it is proportional to the rest of his facial features. I'm going to also note that the nasolabial folds are symmetric. I'm going to close one nostril and ask my patient to breathe to check to see if they're patent. Breathe. The other side. Okay, good, thank you. So now I'm going to move on to the mouth. My patient's lips are pink. Can you open your mouth for me? Okay, I'm going to use my light. So the tongue is pink. The dorsal side is rough. Can you lift your tongue up for me? Okay, and the ventral side is smooth and glistening, and I can see the veins. Okay, lower your tongue. The buccal cavity is also pink and moist. The teeth, can you smile? The teeth are clean. The gums are also pink, and there's no inflammation or bleeding. Okay, can you open your mouth and say "ah" for me? Okay, good. There's elevation of the palate and the uvula. Your tongue one more time. Your mouth one more time for me. Okay, so I'm gonna ask my patient to stick his tongue out. Okay, and then push each cheek with your tongue. Okay, good. Right. Okay, so now I'm going to move on to inspecting my patient's neck. First, I'm going to start by assessing the lymph nodes. So I'm going to assess the occipital, the preauricular, postauricular, tonsillar, submaxillary, submental, the anterior cervical, posterior cervical, and supraclavicular. Okay, and then I'm going to move behind my patient to assess the thyroid gland. The normal thyroid gland moves up with the trachea and the pharynx when swallowing. So first I'm going to assess and have my patient swallow. Can you do one more time? Okay, thank you. And then if you can slightly bend your head forward and to the right. Okay, so I'm going to displace the trachea with my left, with my fingers, and ask my patient to swallow. One more time. Thank you. And then to the other side. Displace with my right, swallow. Okay, perfect. Okay, so now I'm going to assess my patient's carotid arteries. I'm going to palpate first, one side at a time. Okay, so the pulse is equal on both sides. It's about 2+, which is normal. Now I'm going to auscultate with the bell of my stethoscope to make sure there's no bruit present. Can you hold your breath, please? Okay, good. There is no bruit present. Okay, so now I'm going to move on to the cardiac system. I'm going to have my patient laying semi-Fowler so that I can assess the precordium, and I'm also going to be checking some pulses. So if you can go ahead and lay down for me. Okay, so the heart can be examined best at the fifth intercostal space at the apex, which is about right here. In some people, you may or may not be able to see the pulsation on the chest. It normally is visible in children or very skinny people. So I can kind of see it here. It's very minimal, not very noticeable. Now I'm going to move on to assessing my patient's pulses. I'm going to first check the radial pulses. So if you could just... Okay, so the radial pulses are equal, about 2+. And then I'm going to move on to the dorsalis pedis pulse, which is kind of hard to feel. You have to use slight palpation. Okay, and it is present on both feet. It's about 2+ also. And now the posterior tibialis, which is behind the malleolus, and it requires a little bit of a deeper palpation. And it's equal bilaterally, about 2+. Okay. So now I'm going to auscultate, starting in the aortic area. Then I'm going to move on to the pulmonic, and then to the herbs and tricuspid and mitral areas. For this, I'm going to have my patient sit up just so that you can see it better in the camera. So if you can please sit up for me. So first I'm going to listen across the precordium once with my diaphragm, and then I'm going to do it again with the bell. About second intercostal space. So S1 can best be heard using the diaphragm of the stethoscope. It can be heard over any part of the precordium, but it's best heard at the apex, which is this area here. And S2 can also be heard with the diaphragm over any part of the precordium, but it's best heard at the base up here. S3 is best heard with the bell, and it is best heard at the apex, and the same for S4. So starting here, starting at the apex, I'm going to move to, bilaterally down the lungs, and I'm assessing for resonance. I don't want to hear any dullness. And then I'm going to perform diaphragmatic excursion. Okay, so if you could just inhale. Okay, and then exhale. Okay, and then on the other side, inhale. Okay, and exhale. Okay, so the diaphragmatic excursion is about 5 centimeters on both sides, which is normal. Tactile phrenitis, I'm going to ask my patient to repeat the words 99 as I move my hands down his the back. Okay, so 99.
99. 99. 99. 99. 99. 99. 99. 99.
Okay, so I was checking to make sure that the vibration was equal on both sides, and it was. Okay, so now I'm going to assess my patient's lung sounds. I'm going to ask my patient to turn his back facing the camera so you can see. I'm going to use the diaphragm on my stethoscope. And if you could just breathe through your mouth a little deeper than normal. Okay, and turn back around. Face me. Breathe through your mouth. Okay, good. Thank you. Okay, so I'm going to pretend that I'm exposing his abdomen, and I'm going to assess, and I see that the shape of his stomach is rounded. There's no bulging or herniation. The umbilicus is midline, and it is inverted, which is normal. There's no abnormal discoloration around the umbilicus either. And there's no abnormal pulsations. And there is normal rise with his breathing. Okay, so now I'm going to continue by auscultating, because palpation and inspection will interfere with the normal sounds. They increase the sounds of peristalsis. So I'll start at the right lower quadrant at the ileocecal valve. and I'm auscultating all 4 quadrants. Okay, so now I'm going to auscultate for any vascular bruits with the bell of my stethoscope. First, I'm going to assess at the aorta, which is above the umbilicus. Then I'm going to test the left and right kidneys, and then I'm going to auscultate the iliac arteries on both sides, followed by the femoral arteries. Okay, so starting at the aorta. Left kidney. Right kidney. Right iliac. Right femoral. Left iliac. Left femoral. Okay, and I hear no bruits, which is normal. There shouldn't be any vascular sounds present. So now I'm going to move on to palpation. I'm going to first start with a light palpation, about 1 centimeter deep, followed by deep palpation. So I'm starting in the right lower quadrant. Let me know if you feel any tenderness. Okay, followed by deep palpation, about 5 centimeters deep. And I'm assessing for any abnormal masses. And I don't feel anything. Okay, so now I'm going to move on to palpating the liver on the right side here. So just beneath the costovertebral angle, I'm going to use the hooking technique. And I should be able to feel the edge of the liver, which I do. Okay, and then I'm going to come over, I'm going to assess the right kidney. Okay. And then the left kidney, which is slightly higher, it's about 1 centimeter higher on the left side. Okay, and then also the spleen. Okay, and now I'm going to assess the aorta around the umbilical area. Now to percuss the liver, I'm going to start in the right lower quadrant and I'm going to percuss up, and then I'm going to percuss down until I can hear the difference between resonance and dullness. Okay, so starting here. Okay, so it's about 1 centimeter below the costovertebral angle, which is normal. Okay, so now I'm going to move on to the neural assessment, and since I have my patient in this position already, I'm going to ask him to stay here, and I'm going to assess the reflexes with my hammer. So to assess the patellar reflexes, I would direct my hammer to this position right here, and that would assess the patellar reflex. I would expect him to jerk the leg up. And then in order to assess the Achilles reflex, I would direct the hammer to this area right here to assess the Achilles. Okay, so then I'm going to ask my patient to sit up and turn this way. And then to test the brachial reflex, I would put my finger here and direct the hammer here to assess the brachial reflex. Okay, so now I'm going to continue with assessing the cranial nerves. I'm going to assess cranial nerve 11 by asking my patient to look to his right, and I'm going to try to have him move his neck. Well, I'm going to ask him to keep his neck still and try to resist my pull. Okay, so don't resist. Okay, and then look this way. And the same thing. Okay, good. Alright, and then shrug your shoulders up. and then resist my pushing down. Okay, good. So cranial nerve 11 is intact. So now I'm going to ask my patient to, we're going to do the palm alternating test, which is where you're going to do your palm down to your leg, and then you're going to alternate with the back of your hand. Just one hand at a time is fine. Okay, but try to do it as fast as you can. Good. Okay, and now the other side. Okay, good. Okay, so now we're going to do the finger tap test. So I want you to do this with your fingers, and I want you to continue to tap your index finger against your thumb as fast as you can. Okay, good. And then the other side. Okay, good. Okay, so now we're going to do the finger to nose test, or the finger to finger test. So I'm going to have my patient touch my finger with his finger. Okay? Okay, good. Okay, so now we're going to okay, if you can lay back down one more time for me, I'm sorry. Alright, so we're going to do the knee to ankle test, or the heel to shin test. So what I want you to do is I want you to take the heel of your foot, of this foot, and bring it to your knee, to the opposite knee, and slide it down. Okay, good, and then the other side. Okay, good. Okay, so now I'm going to test my patient's sense in his big toe. So I'm going to ask my patient to close his eyes, and I'm going to move his big toe either up or down and ask him to tell me which position his toe is in. Okay?
Up. Up. Down.
Okay.
Down. Down. Up.
Okay, good. And so from here I would use a tuning fork. I would place the vibrating tip of it across the flesh, against the fleshy areas of the toes, and ask him to tell me when he can feel vibration, or if there's no vibration. So I would put it along this area here, around the fleshy areas of the big toes. Okay, so now for the rest of this assessment, I'm going to ask my patient to stand up. Okay. So I'm going to be assessing, performing the Romberg test. So I'm going to ask my patient to stand up with his feet together and hands by his side. Okay, so I'm checking to make sure that my patient is able to stand up straight without swaying, that he can, that he has good balance. Stand up straight. Okay, and then close your eyes. Okay, so I'm just checking to make sure that there's no swaying, that he's able to keep his balance, which he can, which is good. Okay, so now I'm just going to ask my patient to walk forward for me and then back to assess his gait. Well, yeah. Okay, and now we're going to perform the heel to toe test. So straight, I think you can walk this way. Just put your heel to toe. Go ahead, keep walking like that. Okay, good. And then back. Okay, good. So that completes this assessment. I'm going to wash my hands and then document my findings. Thank you for watching.